Hi, everyone. Welcome. So I'm excited to introduce Just Talks, an equity and social justice lecture series brought to you by the Department of Psychiatry's Diversity, Equity, and Inclusion Steering Committee. I'm excited to introduce Dr. Susan Beane and her talk, Long Life with Quality, Updated Care Models to Serve People Living with Mental Health and Substance Use Disorders. Dr. Beane joined Healthfirst in 2009, bringing with her extensive professional experience in managed care. As Vice President and Executive Medical Director at Healthfirst, Dr. Beane focuses on strategies designed to improve the delivery of equitable, evidence-based, value-driven healthcare to our members and communities. Dr. Beane is a strong proponent of collaborating with and engaging providers to improve mental health outcomes and to address social factors of these outcomes. Dr. Susan Beane is an expert in health system transformation as it relates to the design, implementation, and dissemination of innovative, outcomes-focused, value-driven models of care. Her research contributions span the impact on the health of communities through collaboration with stakeholders, health of aging populations and their caregivers, hypertension control in marginalized communities, and maternal health. Dr. Beane is a proponent of the benefits of primary care and is a board-certified internist, as well as a fellow of the American College of Physicians. A native Bronxite and New Yorker, her passion is in the power of partnership with our providers, policymakers, and communities. She works towards an accessible, effective, efficient, and equitable healthcare system that promotes value for all. Prior to joining Healthfirst, Dr. Beane served as the Chief Medical Officer for Affinity Health Plan for 5 years, during which time she helped Affinity's plan become a top performer in quality and member satisfaction. Dr. Beane is a graduate of Princeton University and Columbia University College of Physicians and Surgeons. Faith and family are her first loves, and fitness is her avocation. Susan's superpower is a nature that truly expects the best of everyone. We're so excited for her talk. Thank you for joining us. Dr. D'Amberville will now share how to collect your continuing education credit.
Hello, everyone. Thank you for joining us. So continuing education credits for today's talks are available to psychologists who registered for CE credit and for free for Mount Sinai affiliated physicians, nurses, psychologists, and social workers only. Information to collect CEs and CMEs will be placed in the chat throughout the duration of the lecture. If you did not register via Eventbrite with your Mount Sinai email and would like the free CE credit for your attendance, please use the chat to DM your full name, credentials, and your Mount Sinai email to Timothy Stahl or myself. If you're joining as part of a unit or a group on service, please note each attendee's name and credentials in the chat so we can capture your full attendance. If you have any questions or concerns about CEs or CMEs, please place them in the chat and myself or Dr. Stahl will respond to you. The chat box is open as well as the Q&A box, so we very much encourage comments and reflections and questions to Dr. Beane throughout the talk, and we will do a Q&A at the very end of the talk. And just let us know if you have any concerns. Thank you so much, Dr. Beane.
Good morning, everyone. I am so happy to be here, very excited to share my thoughts on this important topic with all of you. I especially want to thank the team at Just Talks that helped me to take the journey to be with you. Let me share with you a little bit about Healthfirst. Healthfirst is one of the nation's largest not-for-profit health plans. We are sponsored by the voluntary hospitals in our region. It's a unique model. It's a provider model, which means that medical directors like me and my teammates are able to really go out there and promote value-based care as we're doing today. We're about over 30 years old, focusing on these communities. And we think a lot about quality, and our hope is that we can help create a vision of a new transformed health system that really benefits all. So my aim today is to explore a bit the opportunities for primary care, and behavioral health, and other like-minded colleagues to implement care models for the populations that we're jointly serving. And today, I hope to convince you that long life with quality is a central factor in value-based care. We'll talk together a little bit about what this means in terms of long, healthy lives and misery for people across the globe and also in the United States. Then focus in on mental health diagnoses, using that focus to explore the intersection between health and value. I'm an MCO participant, so it is important to bring forward that part of care delivery. And then we'll finish up by updating some of the care models, specifically integrated care. And we'll talk about how I believe this can transform wellness for people living with mental illness and substance use disorder. So that's a lot. So let's start by talking about the framework that I'm going to talk about here. And this is the Healthfirst model for how we collaborate with providers and others. The quintuple aim will define who I'm talking about, the stakeholders today. I'm going to talk about the point of view of our patients, members, people. I'll talk about efficiency and experience of care. I'll also talk about how providers feel when they're experiencing care, something Mount Sinai has done a lot of work in, especially during and after the pandemic. And then we'll put it all together, believing that we can all reach health equity. So let's start with long life with quality. And this slide I'm putting into all my talks because why are we interested in value-based care at all? It is really because it's not positive that the United States is the country that sits at the top in terms of health spending per person, and that spending does not result in longer life expectancy. And so this combination is where we have to achieve value, increasing life expectancy while decreasing the dollars that we're spending. And this is not a new issue. It is long term. You can see the data through 2022. You can see the impact of the pandemic, especially on the United States. And we have a lot of work to do. So long life is tied to burden of disease. And we're going to talk about some of the terms that are used, which you may be familiar with. I want to focus a lot on healthy life expectancy, or HALE, years of potential life lost, years lived with disability, and combining all of that to understand disability adjusted life years. I think that's very important for this talk because it sums up the years that are lost to premature death, as well as years of healthy life lost. I call that the miserable years, and they're miserable and shorter. So let's get into it a little bit. So I'm always fascinated by how the World Health Organizations and others are viewing the global causes of death. And, I'm giving you many references here that I hope you'll follow up on. I can only touch on them briefly. There's a lot of deep information here, but you can see that in 2022, ischemic heart disease, stroke, COPD, COVID, lung cancer, Alzheimer's, diabetes, chronic kidney disease, etc. These do not surprise you. These are not dissimilar, you'll see, to what are the leading causes of death in the United States. However, when we go to the leading causes of disability adjusted life years, you can see that mental health disorders and substance use disorders rise into the top 10. In fact, if you add together the count in terms of millions of lives across the world that are impacted by depression, anxiety, and self-harm, you begin to almost see a similarity to a physical health disorder, which is stroke. And recently, there's been some work that suggests that even using this approach, which was my fuzzy math, is underestimating the burden. So let's move on to a little bit closer to home. Let's talk about the United States and New York State. So What causes the most death and disability combined in the United States? This graph is showing you the percent change between 2011 and 2021 for all ages, and you'll see that the greatest trend in terms of death and disability is really drug use disorders. And then you see some interesting findings. For example, lung cancer has decreased some over these 10 years in terms of its impact on death and disability. So this is something we have to track over time. But again, these disorders do not surprise us. And in fact, the reason I really appreciate this view of the world in terms of burden of health is the punchline here is that risk factors are the key. So risk factors and addressing risk factors leads us to this new prevention and wellness approach to the health of the people that we're serving. And you can see the ranking across these various conditions, condition-causing risks, body mass, glucose, tobacco, dietary, blood pressure, drug use, kidney dysfunction, alcohol use, high levels of lipids, and of course, occupational risk. And you can see that I've listed them here in 2021. You can see some of them change rank over time. But it's really fascinating that high body mass index is really at the top of the list. Well, here's the burden of mental health diseases. You can see that I've tried to line up these two SAMHSA visualizations so that if you go from left to right, you'll see for both female and males, and also by age band and also by race ethnicity, the prevalence of any mental illness among US adults. Again, this is 2021 data. And you can see that the prevalence is about 33%, and among US adults for 18 to 25, you can see the other years, and then you see how the services line up. So what that says is if I'm living with a mental illness, 44, 48, 47% of us are getting the services that we need. And I think this is not going to surprise you either. This is a real seminal study looking at premature mortality using a very sophisticated methodology. This was looking at populations from 2001 to 2007, published in JAMA in 2015. And you can see that in the Medicaid program, you are 3.5 times more likely to die during the study period if you are living with schizophrenia. Natural physical health, however, is what causes and drives the mortality, cardiovascular, diabetes, cancer. But for younger age bands, natural deaths are superseded by unnatural deaths, if you will, suicide, accidents, homicides, etc. And more recently, this view of longevity has been updated to show that, and this is across the world, but there are actually 21 studies from the United States included in this meta-analysis. And you can see that years of potential life loss due to a combination and, sort of all of the disorders or conditions that are in being considered. And this is like detail that you can't see, but I'm just showing you the pink bars are United States. It differs across the world, but at the end of the day, it's about 14.7 years. And again, I am not going to try to decipher this. This is actually an interactive tool that is available to you on healthdata.org. And what it shows basically in New York State is that deaths again, are driven mainly by metabolic risk factors. So in other words, addressable risk, as we've said before, while disability is a little different. So living with disability is driven by many of the same disorders. However, you see that behavioral health conditions contribute a greater portion of that drive toward disability-adjusted life years. And in New York State, indeed, this is really fascinating study that's done every 2 years by the Office of Mental Health, the State Office of Mental Health, you can see that many of the people who are receiving care in an Office of Mental Health facility are living with one or more chronic medical conditions. In fact, the majority are. And here are the chronic medical conditions. I didn't rank them, but you can see that obesity, and pulmonary diseases, and then you sort of see endocrine, etc., rise. What I will say, the way that I look at this data is that obesity to me is part of the metabolic spectrum. So if I'm seeing obesity, I'm worried about all of the contributors to cardiovascular disease and other poor outcomes. And why do we worry about this? Not only in New York State, but across the United States, across the world, frankly, um, the medical treatment costs for people who are having both chronic medical and comorbid mental health and substance use disorder is 2 to 3 times higher on average. And so Milliman, which is one of the great contributors to understanding the economics of health in our industry, suggests that value-based costs actually would occur through improved outcomes for medical conditions. All right, so we are wanting to make lifelong wellness our goal. And for me, perhaps for you, I believe that's a paradigm shift. So, in order to talk about that, we first have to look at our healthy years versus life expectancy. And in the United States, you can see our life expectancy at birth differs by gender, and as well as the healthy years that we're going to experience on average differs also by um, gender. Now, you can see that we're expected to only have about 67 healthy years if we're women and 64 years if we're men. The other years are going to be impacted by disability or other manifestations of poor health. There's some other interesting math here if you look at this up and you sort of take a view of what the aspiration is, which is to improve life expectancy as well as the number of healthy years. This is of great interest to the Medicare program, as you can expect, and this is work that was done in quite a while ago, published in 2008, and this is some of the foundational work that has been done to fuel innovation in the Medicare program and other programs as well in terms of benefits. So this is just giving you a view of what we look at every day. So we're all working on stroke and hypertension and cancer, and we want to decrease them with the hope that that will actually slow the increase in total healthcare spending. What this model shows is that this innovation will indeed, these kinds of innovations, improve health and extend life, but they will probably increase and not decrease Medicare spending. However, if the innovation looks at prevention as the driver, going back to what we've already talked about in terms of risk factors, what the Medicare predicted is that there will be a net and pretty large decrease in total spending. So this is sort of projecting out to 2030. It's really interesting. You see that if we eliminate all smoking, we actually increase costs. Diabetes, same thing, perfectly controlled. But even with that, eliminating hypertension, obesity, we begin to get to the point that we can really bring value to the discussion. So I love this because it's longevity plus the efficiency or spending. Now, we are all familiar with a lifespan approach to how we view our populations. The top chart is very familiar because it's looking at adverse events during childhood and the impact on the trajectory of health. We want to have a healthy trajectory, but various impacts can change that to less health or even poor health. And there are mitigating factors that can improve health. Well, these impacts actually can affect the trajectory of health across the whole lifespan. And so, the top graph starts with, people who have high social status and great parenting, but experience some, negative issues along the pathway to older adulthood. Um, the lower graph shows us someone who is less wealthy and has various kinds of impacts, positive and negative. What's interesting is in the older age group, you see work-life balance versus job insecurity. These are economic influences that certainly do affect the trajectory of health. So if we're going to talk about new care models, what we want to do is intentionally promote health and mitigate risks. Now, this onion is looking at the distribution of mental health and substance use disorders, mental health disorders across the lifespan. This is global. What you're seeing is male on the left, female on the right. You can see how the spread of disease happens or these conditions happen across the lifespan, beginning very young, at very young age. The middle of the onion, if you will, are depressive disorders, anxiety, and schizophrenia. I like this chart, however, because what it says to me is that the rise in mental illness, and again, the mental illness portion is sort of this navy blue bar, which you see in men, in women, and also men. And you can see that the rise in the impacts of mental health and substance use disorder actually rise with all of the chronic diseases that we're concerned about across the lifespan. So with that, I feel comfortable that we can truly say that we are taking all of these factors into account as we move into a value-based world. And in this value-based world, we are taking a sort of a different look at traditional healthcare. The transactional care, which for health insurance and managed care is very familiar. We want to offer our patients care. We want them to be healthier, but we're the provider side. We need money, time, understanding. We need a social life, etc. And there are trade-offs because sometimes the system of care doesn't really help me as a provider do everything that I want to do, my fears, my emotions, and so on. The health consumer is similar. They're transactional in terms of wanting the great health care that's going to change their quality and length of life. They need the same things we do because we are them. And the trade-offs are also very similar in terms of a system of care that doesn't always see or hear our needs. And the reality from my perspective is the balance between our capability to heal, if you will, as physician and other health professionals, versus our finance office that's saying to us, no margin, no mission. This we're familiar with because it's how we think about all of the impacts on health outcomes that people experience, from the physical environment to social, economic, clinical care, health behaviors. All of these contribute ultimately to length of life and quality of life, as we have discussed. However, the challenge here is that even though we all have great intention, and we're in the midst of our 1115 waiver, this is really still fragmented from the point of view of the people that we're serving. And so what we want to do is change the paradigm a bit to make it more holistic, more relational, more integrated, and connected. And people will appreciate this because, especially people that you're serving, for example, with mental illness, or we're all serving, they long for healthy lifestyle changes, just as everyone else does. But as you know, it's very difficult to give up the relief of some of our unhealthy behaviors when we're not really fully treated or managed for our mental health symptoms. So holistic care, I'm not going to go into detail, but this is really new models of how we can address root causes of chronic diseases. Relational care, this is a plastic surgeon in California who's actually fascinating. And she actually opined on relational connections and how it's rewarding for both her patients and for her. I always start out by saying we get to know our patients head to toe, inside and out. This is Dr. Horton's perspective. And then integrated care, which you're very familiar with. You have models of this here, and you're a pioneer in this area. And so this is looking at 313 primary care physicians in Michigan, and try to understand how comfortable primary care physicians and how confident we are, if you will, in screening for, diagnosing, and treating mental health and substance use disorder. And I'm making the case that we do need integrated care because, as much as I'm sure we all want to, primary care is not the best place to find some of the more screen for and diagnose and treat some of the more complex disorders that our patients are suffering from. Frankly, the patients feel the same way. You know, our family doctor's good, but they don't have enough time to spend with you as a counselor. You know, and the feeling here is that, and it's probably true, PCPs do not actually have enough knowledge of both the medications and the full spectrum of opportunity for treatment of these disorders. And so patients, when surveyed, this study 2022 found value in that integrated team-based care setting for all the reasons that you would expect. However, you know, the integrated care model can be improved, and you can see here that patient experiences are both positive and negative. You know, certainly the structure of care makes sense, the centralization, you know, destigmatization that happens in an integrated team-based model, but it doesn't quite get to all of the concerns that people have around advocacy and our patients feeling like I have to be my own advocate, as well as the process of care, even within this great structure, still seems disjointed and fragmented. We do know that patients see the integrated care as more favorable for the model where the specialists and the PCP are operating jointly in terms of patients receiving both the medication and counseling that they desire as full treatment. And you know that creating integrated care is complicated. There's stakeholders. I don't need to list them. There's all the structure and the processes that need to happen. But I want to call out for a moment what it means to staff when we're actually changing it into an integrated care model. This is a study that was done in the UK, a randomized controlled trial. It was really interesting because what they did made sense. They trained and supervised staff to be able to work on lifestyle choices and substance use. So this is holistic for their patients as routine care, but it was not a successful study. And the reason is that the care coordinators were not able to successfully add and build in the new coaching methodology for their patients so that the cardiovascular disease didn't always get addressed. And there are other studies that are emerging now to show that, you know, care teams actually have feelings about how care is rendered. I'm not going to look at the red bars, which are what the patients are saying, but here the care team was found to have in fact, they were upset by inefficiencies, access barriers, coldness, and miscommunication. So putting this all together means that we need to integrate care with intention for all stakeholders. This is a model that was implemented by Acacia, who is New York-based, successful. They gave us a glimpse into how they did this. They're a really interesting model with residential care and really great understanding of substance use disorder. But you can see that even for them to do this, they had to look at their data, brainstorm, test, roll it out, train, do metrics, and also track and monitor. This is another model that's put forward by the National Council for Mental Wellbeing. Some of our local colleagues contributed to this over time, this integrated model where theoretically we can have certified community behavioral health clinics that provide holistic care. And this is sort of just looking at this whole model. It is complicated. So you have the context, the organization, social activities. You can see that it's not just deciding to do this, but rather for all of you who are trying to do this, it's pretty complicated to get from, you know, the problem that you want to solve through the outcomes you want to achieve. And here's a great example. This is an illustration where we have a patient who lost his job. He's 65. He has bipolar, alcohol use disorders, and hypertension. And he goes to his behavioral health clinic. And in the middle of that experience, he gets his care planning integrated, which is his medical care with his social needs. And you can see how the outcomes are better. But I'm going to put forward that we may need to consider how we can build on integrated models, especially if we're wanting to fit these models into a value-based paradigm. Now, I am going to assume that primary care is the foundation. And the reason I say that is when you look at quality historically, and this is sort of the CMS model for how they believe quality will set the tone for all the models that we're going to talk about. Quality happens across the care journey: equity, safety, engagement, resiliency, innovation, this alignment to produce seamless and coordinated care. That's quality. That's what our strategy should be. But I'm going to focus in on embracing the digital age because this is sort of the revolution that's happening in terms of evolving from traditional models to value-based models. And that is, you're not working on paper, so I don't have to say that. You have your electronic health records, you produce data from it, but there's a movement toward what they're calling digital quality measures. You're going to experience this in the 1115 waiver, where data from all different sources are pulled together to find answers and to create metrics. This is very ambitious, but it's already happening. You may have heard of FHIR, which is how these various systems interface real time. Now, for Healthfirst and other payers, we are already finding ways that we can use this to improve outcomes for our populations. And so this digital quality measurement roadmap is the foundation, if you will, the structure upon which the processes of care are going to be built going forward. And you can see in the graph at the bottom that all of this is going to come together to improve patient care. This brings me to NCQA, which is the National Committee for Quality Assurance. This is how we actually have agreed to standardize our industry, mostly in the ambulatory setting. So you have other industries, auditors and standards like JACO, for example, that drive standards for our industry. But this is looking at the primary care side where the value particularly happens. And NCQA is really interesting because they actually start with their definitions of what needs to be addressed: social determinants, risks, and needs. The needs are what the people we're serving actually need done for them. And then all of this drives toward eliminating health disparities and achieving equity. So what I wonder is there a potential role for the kinds of standard certifications and recognitions that NCQA creates for the unfolding value-based model? I'm going to run through these really quickly, but you can see that we're accrediting population health programs. And traditionally, this has been health plans, various kinds of vendor organizations, and then primary care that have looked at receiving this stamp of accreditation for the work being done. But you can see that we need population health standardized so that we can all improve the journey toward a better healthcare system through operations, contracting, and value. Certified case management, a lot of my colleagues are actually on the line today, I believe, and they pointed out to me what I already knew, but needs to really be thought about, that certified case management in our industry has historically been what we actually do to create this sort of smooth experience for people in our systems, especially as they move between care settings, especially as they need advocacy. There's behavioral health integration with primary care, which is a way to make behavioral health practices even more conversant with how integrated care can happen. This is fascinating. So any specialty practice can become recognized for working well with primary care, proactively coordinating and sharing information. And any organization now pretty much urgent cares, and retail clinics can all become recognized for having patient-centered care. But what does it do? Connects with primary care to identify the risk factors and needs that people have. So I've taken you on a whirlwind here. We've talked about longevity with quality, which is the foundation of how we're going to make people live longer with quality. We've talked about integrated care models, which you're very familiar with. Primary care is becoming more familiar with. And we've talked about standardizing all of this so that it's a smooth, connected system of care. So let me give you my thoughts on how this comes together and informs an ecosystem which is value-based. So just walk with me here. So the first thing I want you to look at on the left is my opinion about intentional focus. So in all of my experience in many, many years in this industry, as a practitioner myself years ago, the intentional focus on the objectives of longevity with quality, I believe, are going to be the central driver for great care and great financial results. This means that we're increasing healthy life years, which are less expensive to the system, by addressing root causes, engaging lifestyle in a relational way, not sort of a you better do this way, and the advocacy piece. So every part of what I described to you is in this little onion. So I'm going to put case management at the base of this because something has to connect the dots in our fragmented system. And then you start with the patient, you go to the primary care being portal and hub. Then within practices like yours, there are collaborators with primary care. Let's say they're behavioralists. There are other partners outside the practice walls that will covenant to make these value-based propositions come to pass, as well as the whole healthcare system. You're seeing that sort of the 1115 waiver. Well, now we're bringing in social services. This has to be driven by digital connections and analytics, as well as innovation. And all of those models that will afford standardization, I've listed at the side of this. So you sort of see how these two axes can come together. And here's the same model of innovation that we showed you, in terms of a person receiving whole person care. I like this circular model as a future model where there's no sort of beginning and the end, but rather we're wrapping all of this system around our patients, our members. I believe this has to be anchored by case management. And that's because the community support, CHW support, peer support, all of this is important, but there have to be professionals who actually bind all this together so that we on the physical health side, behavioral health side, are all contributing to a seamless, a feeling of seamlessness that I don't believe our patients and members are feeling quite yet. And then finally, this connected care model is how you sort of create the healing process and the reimbursement process. So here we bring together value. You can see team-based care, I've kind of highlighted in terms of the integrated delivery system. Maybe it's not a closed system of care. Those are very hard to achieve unless you're like Kaiser Permanente. But you can see here's our same integrated model with all of these standardized ways of doing this. This is, yes.
Dr. Beane, can I interrupt? Your slides are off the screen. Do you mind pulling it back up?
Wow.
It just went out, no worries.
Are they gone?
Yes.
You can just look at my hands. This is my last slide, so let me see if I can get it back up there.
No problem.
Wow, that's really, really weird. Do you see them now?
Yes, thank you.
I don't know what I did. So my hands are saying that these evolving payment methods are currently in test. They've been tested by Medicare and CMS. They're expanding to other payers. And you're sort of seeing this kind of onion that I've illustrated here as a foundation for moving forward with these evolving payment methods. These evolving payment methods are important for not just big organizations, if you will, integrated organizations like yours, but also independent practices, because they are where most of our patients and members experience care. So, health outcomes, that's our intention, with length of life and quality life being the shared priorities for every person, including those living with mental illness and substance use disorder. And then the advocacy part, the empathy part that has to drive the seamless experience of people across the care system. I took the same graph or visualization we're used to in terms of the social determinants, and here I put it into one system where all of this happens, not in a fragmented way, but all together for the people that we're serving. Health outcomes driven by our avoidance of risky substances, but also increasing the great lifestyle opportunities we all have, giving great care, and then making sure that people have access to ongoing social services, economic services, and advocacy. Whew. So that is my whirlwind tour for you through what I envision as some of the new opportunities for care models as we move forward in this value-based world. So thank you for your attention, and I'm looking forward to questions. Thank you. Thank you. Thank you.
Thank you, everyone. Oh, people are saying they can see the slides, so maybe that was just me. So please, everyone, put your comments and questions questions to the Q&A. Welcome to put them into the chat as well. Any thoughts, reflections on Dr. Beane's talk. And as we await some comments, Dr. Beane, we have some questions for you. So firstly, thank you so much for your talk and the emphasis on how healthcare systems can really better shape access and provision of services, particularly integrating this community model. So the first question I have for you is, can you share your own journey into this profession and community work and how you found yourself in your role at Healthfirst?
Sure. So I practiced medicine for a few years after residency. But I'm very lucky that I actually have a partner, my husband, was in insurance, and therefore I began to understand how the finances of insurance work, and that really formed the foundation for my career in health insurance first, and then managed care. And I think that the policy side has always been very interesting to me, and I just happen to love working with providers and beneficiaries. They all have my email address, my phone number. I still live in these communities. But I think that that's kind of what fuels my passion for this topic.
Naomi, you're muted.
Sorry. What advice or I don't know, thinking in terms of your own trajectory, but for trainees or licensed clinicians who would want to either in the clinical space or thinking about connecting, collaborating with systems like yours, like how does one get involved? Where does one start? What are the questions they would need to ask?
I think that most of the health systems, most of the practices that are sort of the undergirding of Healthfirst and other health insurers are already thinking about the quality. Quality is the first piece. And so what I would say to any trainee or new doctors is you really have to understand how quality impacts populations, understand the numbers, and really stay up to date with some of the data that I showed you, which is population based. I think you can leverage that then to begin to connect the dots to being having more of a role in driving system change and transformation. But it all begins with a point of view. And what I'm finding among trainees that I get to talk with is they have a point of view. I recently saw a Mount Sinai presentation, Dr. Butts's group, and what they're doing, and they talked about humanity, was the driver for them. So you have to have kind of a point of view that fuels this. If you have that point of view and the understanding of where we need to get to, I think that you'll find pathways. There's so much opportunity in terms of things that need to be done.
Thank you. Sydney, any additional questions? You're on mute.
I'm muted. Let me just see. It looked like there was something in the Q&A. Where does a provider find a case manager or advocate for a patient? Do they find that through their insurance, through their community? What recommendations do you have for
All
accessing those kinds of
right.
supports?
All of the above. And actually, um, there is an organization that, is sort of the advocacy group for certified case managers and also provides their certification, CMSA, the Care Management Society of America. And I am glad to give you more information about that. That lists many, many certified case managers who could be interested in working with you. Short term, long term, to build that advocacy part of the experience. There's a colleague of mine who actually is a leader in that organization, Alan Boardman. So please feel free to contact me, and I'm glad to put you in touch. I have worked with case managers like that in my career. I used to tease them that if it benefited a person or a patient, they would negotiate for a pencil. These are folks that take the deep dive into what every person needs to meet their health goals and will work with us collaboratively to get there. And of course, Healthfirst Managed Care has all of us. We all rely on these case managers for helping our most complex members. Can I say something before we close? I'm really inspired by all of you. This really came together out of some of the questions that you asked me and some of the work that we're doing together in Harlem around how can we really get to the value. And I think that physicians and health professionals across the country that I meet are all concerned about keeping that healing feeling and not losing the care of people even as we're trying to reach financial results. So I think you've tried some pretty amazing models. I couldn't include them all in my presentation, but I really applaud you, especially with the DEI focus in mind. So, kudos to you, and you're inspirational to me. And I look forward to working with all of you more in the future.
Thank you so much, Dr. Beane. Some additional questions. So you were speaking about these, that visual you gave with sort of the patient and the circular model, as well as the connected care model. Curious, so what has been like the mechanism for patient feedback into these models and services, and how has that feedback and their voices been incorporated into improving the services?
Great. That's a great and important question. So these organizations, these multi-dimensional organizations, usually get funding to get started. And the way they do that is to embed the patient voice in two ways. So number one, surveys. So the experience of care is something that CMS is very interested in. We're all at the health plan level having to do that. And you do it too, in terms of being a healthcare organization. But using actual patient focus groups, going out into the community, working with community-based organizations who are keeping the pulse or hearing the voice of people in the community is rich. There's so much that we can learn there. And there's some work that's being done where no new program is rolled out until the voice of the consumer is represented in the initiative. And if they say one thing needs to be changed, that thing is changed. So this is not a new concept. Johns Hopkins did some work in this many, many years ago. Being comfortable, though, and vulnerable enough to actually hear what people say, because people are not always positive about this awesome work that we're trying to do. So we have to feel that that's the relational piece, that, your voice, if you say that, you talk too fast. I would used to be called the doctor that talks too fast, literally. That was for my patients, So, I think we all have to be able to hear some things that are negative as well as positive. And that's, our CEO used to say that, these are our jewels. This is how we actually improve. So that's what I would say about the patient voice. You have to seek it out.
Mhm.
Lastly, I believe that we have to stop being us versus them. They experience things like this. They don't take their medication. So we are they. we are they. And so I think to the extent that we realize that we are potentially going to encounter the same concerns that our patients and members do, it helps to make it more likely that we're going to listen to the patient voice.
Of course, I mean, I think everyone has had the experience of, frustration and barriers as they've navigated their own access to care, whether medical or mental health care. It's a frustration that is widespread. And I think that the idea of we are they is so, so important because we want to take care of ourselves, we want to take care of the community, and we all have to coexist. Yeah, so the patient-provider relationship is not one that is adversary, but is meant to be healing. But I can see how so many people may experience it differently.
Yes, exactly right. Exactly.
I believe we have a question in the Q&A.
Yes, we have one more. What can a frontline clinician do to address social determinants of health impacting patients within such a fragmented system?
Wow. Yeah, that's the hard part. And that's the reason we need these integrated models. But what I would say is that social determinants, I don't wake up today and say, I have a social determinant. Neither do you, right? I might wake up and say my care is disparate, but I'm not going to say, my social determinant, is driving me. But when I'm relating to my provider, I want to tell them my needs. So if we focus on that middle bar, the social needs, and prioritizing what that person is saying to me, which in their perspective is driving potentially poor outcomes, I think that there's a lot of success that can happen. I do feel that historically providers are a little bit disadvantaged because we don't all have access to social workers. We will. So you do have to do a little bit of research. I think that's changing, that there'll be more community-based organizations around. However, if you're serving a community, go to the community board meeting, meet the community base. I mean, it takes a little bit of energy, but it'll pay off in the long run.
Yeah. Um,
I see there is an issue that social workers and insurance companies, yes. So I've worked and collaborated with the social work teams in many, many companies. The issue for us becomes we rapidly become part of the system. So you're DEI, so you understand when I say systemic racism, right? Or systemic isms. We, to survive, have to become conversant with that system. I do believe that in the future, certainly always call your managed care organization, including Healthfirst, for help with complex patients and members who have needs. Absolutely. However, this is going to move more and more toward the community, I believe. Many of our insurance companies are not, we are in New York. We are here, we're hyper local. Our case managers are out in the field, but that's not always true for your patients. So, you know, um, this is the billing, the reimbursement for all of those pieces that I put on my slide is changing. And the reimbursement methodology, the amount of reimbursement is going to be addressed, and the ability for practices to be compensated, if you will, for including social workers, health workers, and peers in the practice, navigators, is going to be um, more and more available. That's what on the Medicaid side is what is happening with the 1115 waiver, but Medicare is also going in that direction. And yes, the community, that's when I say the patient voice in the center, I believe that that patient voice is the community. And so some of us experience that through organizations who are advocates. So I do believe that they will be part of this vision for teams. But we, as healthcare consumers, have to really, if you will, demand that we have to teach people to advocate for themselves in that way.
Were you responding to the question about the community being part of the, yes, okay.
Yes.
I guess one last question. What do you see as and I know you spoke about this in your talk, but can you just say a little bit more about the biggest challenges for integrated mental health care? Do you anticipate in the sort of coming years, especially around as policy changes, as the diversity and the needs of the community changes, but what do you kind of see are the challenges on the ground?
Yeah, I'm going to say first on the physical health side, we have to adapt to the person not finding the primary care physician or primary care practice as their point of entry. So I think the challenge is to the system at large. So if you're seeing the person for the first time that they're going to trust the healthcare system, you're on first base, but you still understand that the intention has to happen with good primary care. The primary care physician is what I view as the portal or the hub of the primary care practice. So I think the challenge is really, investment. As I showed you in the UK, they showed that just piling it on doesn't make it happen, and looking at populations holistically and being humble to say that, half of my patients come to me from the psychologist down the street. That's fine. And also for the system of care, we're going to have memorandum paper understanding. We have to share incentives. We may have to share what we receive in funds in different ways. So this is the beginning. You're going to see this evolve over years, but the challenge really is going to be not to try to change the current system, but to transform it.
Thank you so much. Any last comments or questions? Okay. So thank you again, Dr. Susan Beane, for joining us today. And just so many nuggets of like the idea of people being inspirational, the sort of we are they, the healing feeling. I think that these are things that each of us can take back and reflect on in our own lives, as well as the work that we do as providers and administrators and staff, right? I think everyone holds a responsibility to help better provide the services that our community needs, particularly the people we serve in East and West Harlem. So I hope all of you who have attended today really enjoyed the talk and found it relevant to your practice and the communities that you serve. As a reminder, this is the first Just Talks lecture for the 2024-2025 year. Again, these lectures center on the intersection of the social determinants of health, psychiatric illness, and mental wellness. And we look forward to being in community with you all over this next year. And I will be putting into the chat the Just Talks YouTube page web link where Dr. Beane's talk will be posted at some point in the future, where you can also view past talks. Thank you so much for joining us. We'll see you next time in October. I don't remember the date, 25th? That's a guess. 23rd, I believe. October 23rd is the next Just Talks. We'll see you then. Bye, everyone.
So much. Thanks, everyone. Have a great day. Thank you. Thank you.